Dear Chairman, thank you for the invitation to present at the EBC 2021 meeting. The title of my presentation is Stent-less Procedure, Effective DCB Treatment. This is my disclosure slide. In current guideline for the treatment of bifurcation lesion, single stent strategy is a major method. In United States also, European countries also. Of course, Japan too. When I considered about current situation, I have some questions. As I showed, single stent strategy is reliable treatment method. Will I need stentless procedure in this day and age? What situation will need stentless procedure? What will be the reliable stentless procedure? Considering about the candidates for stentless procedure, some conditions may apply like the following. As regarding patient background, we can say these things. In Japan, many doctors want to avoid to use stent for young patients, especially less than 50s. As regarding lesion morphology, I think these two situations are important. About the reliable stentless procedure, DCB is paid attention recently. In the last EBC, there were some comments about it. This paper reported the effect of paclitaxel coated balloon for side branch in two bifurcation region from China. In comparison with conventional balloon group, rate lumen loss in DCB group was significantly smaller, and incidence of MACE was also significantly lower. From Japan, Dr. Kitani's group reported the efficacy of DCB after plaque reduction. They evaluated outcomes of 129 DCA-DCB cases without stent use. In this study, true bifurcation region was 14% and more than 70% of main target was in the main branch. TRR at 12 months was 3.1% and it was quite low. Clinical outcomes were pretty good totally. In this study, there are no differences in minimum lumen diameter and percent diameter stenosis between post-DCA and follow-up, despite stentless procedure. This may mean that aggressive plaque reduction facilitates the effect of DCB. According to the data of 247 patients treated with DCB in my hospital, lesion preparation less than 58.5% in plaque area was important in stentless PCR using DCB. Let me show my case. This patient had a severe stenosis in proximal circumflex and mild stenosis in proximal LAD. To avoid the compromise of LAD, I performed directional atherectomy to the circumflex. After atherectomy, angio and IVUS image looked pretty good. And then I dilated the proximal circumflex with cutting balloon and DCB. Final angiogram showed good result. 1 year later, there was no restenosis. Next case was 60s male with 111 left main disease. As I wanted to avoid complex stenting and carina or plaque shift, I performed atherectomy to both branches. After atherectomy, I dilated proximal left circumflex with cutting balloon and DCB, and then I put 2 synergy stents because main branch lesion was very diffuse. After putting stent pot and minimum case was performed to fix this trifurcation. Final angiogram showed good result. Although dissection was recognized at proximal circumflex, I decided to observe it because dissection was not malignant on IVUS image and the percent plaque area was 46%. This dissection healed completely and there was no restenosis at follow-up. Ladies and gentlemen, this is my conclusion. Although the cases which need stentless strategy may be rare currently because of the development of DES, there will be some situations in which stentless seems to be beneficial for the patient. DCB may be a potential strategy for the treatment of bifurcation lesion when we aspire for stentless procedure. However, some kind of region preparation, such as plaque reduction, will be needed to make DCB more effective. Thank you for your attention.